What's up, EMNE fam? Today we're coming in hot with another lecture. Today we'll discuss how to interpret EKGs beyond ST elevation and depression. During this lecture, you will obtain a useful mnemonic to remember EKG findings indicative of a cardiac event, identify abnormal EKG findings beyond simply ST elevations or depressions, and understand the coronary anatomy behind many of these EKG abnormalities. Before we take a deep dive into this material, I must beg the question, what season are we in? Fall? Winter? Ladies and gentlemen, we are in the heat of cuffing season. For those of you that are unaware, cuffing season usually occurs during the colder months, fall and winter, when new relationships start and old relationships turn into engagements. The person in said relationships are cuffed, meaning they no longer seek non-platonic relationships with others. As you can see from this very scientific diagram depicting the cuffing season basics, there is a sharp decline in the need to be cuffed from spring to summer. However, as we approach the colder months like November, December, January, and February, the need to be cuffed is at an all-time high. Like bears hibernating for the winter, individuals need a boothang during those colder months. We will use this season to help formulate our mnemonic for remembering EKG findings beyond ST elevations and depressions. Wellin and Helen split up during the winter, and now they are all depressed. Let's start with Wellin, which stands for Wellin's Syndrome. Now, Wellin Syndrome is a pattern of deeply inverted or biphasic T waves in V2 and V3, which is highly specific for a critical stenosis of the left anterior descending artery, as you can see here. As you can see, we have the classic biphasic T wave pattern in V1, V2, and V3. And here we see the deep inverted T wave pattern in V2 and V3. The thing about Wellin syndrome is that patients may experience chest pain or may be completely pain-free. They are at extremely high risk for extensive anterior wall MI within the next few days or weeks. Due to the critical LAD stenosis, these patients usually require invasive therapy. Patients often do poorly with medical management and may experience MI or cardiac arrest if inappropriately stress tested. Now returning back to our mnemonic, Wellin and Helen split up during the winter, and now they are all depressed. And then there's Helen. Now Helen stands for hyperacute T waves. These are broad, asymmetrically peaked or hyperacute T waves are seen in the early stages of ST elevation in MI and often precede the appearance of ST elevation and Q waves. They are also seen with Prinzmental angina. Here we can see the classic hyperacute T waves in V2 to V3. These same hyperacute T waves later develop into the classic ST elevations that we're all too familiar with in V2 and V3. Now, hyperacute T waves are often the first manifestation of complete vessel occlusion. They are wide, bulky, and prominent. But hyperacute T waves are very different from the peaked T waves that result from hyperkalemia. Hyperacute T waves are wide, bulky, and prominent, while peaked T waves, on the other hand, are sharp, pointy, symmetric, with a narrow base. Moving back to our mnemonic, Wellin and Helen split up during the winter, and now they are all depressed. Now, split up is an acronym within itself. The S stands for Scarbosa criteria. Now, in cases of left bundle branch block and ventricularly paced rhythm, during these rhythms, the baseline ST segments and T waves tend to be shifted in a discordant direction called appropriate discordance. This appropriate discordance can oftentimes mask or mimic acute MI, and for that reason, the Scarbosa criteria was developed. Now, there's three components to this criteria, the first of which is concordant ST elevation greater than 1 millimeter in leads with a positive QRS. Second, concordant ST depression greater than 1 millimeter in V1, V2, and V3. And lastly, excessively discordant ST elevation greater than 5 millimeters in leads with a negative QRS. Now, these criteria are specific but not sensitive for myocardial infarction. A total score of greater than 3 is reported to have a specificity of 90% for diagnosing myocardial infarction. But then came the modified Scarbosa criteria. Now, the biggest change is related to the rule for excessive discordance. The modified rule is positive for STEMI if there is discordant ST elevation with amplitude greater than 25% of the depth of the preceding S wave. For example, based on the old Scarbosa criteria, we can take a look at the left image. We see that this is not an acute MI based off of the old criteria because the excessive discordance is less than 5 millimeters. It's only 3.5 millimeters. However, using the new Scarbosa criteria, in which the ST elevation to S wave ratio must be greater than 25%, we see that this is an acute MI because the ST elevation is 3.5 millimeters, the S wave is 10.5 millimeters, 3.5 over 10.5 is 0.33, which is greater than 25%. Therefore, this is truly an acute MI. So, bringing it all together, with the modified Scarbosa criteria, we have concordant ST elevation greater than 1 millimeter with a positive QRS, concordant ST depression greater than 1 millimeter in leads V1 to V3, and at least one lead anywhere with 1 millimeter ST elevation and proportionally excessive discordant ST elevation as defined by greater than 25% of the depth of the preceding S wave. These are the criteria for the modified Scarbosa criteria. Moving back to our acronym within our mnemonic, split up. Now, LIT, well, the second P stands for Posterior MI. Now, posterior infarcts accompany 15 to 20% of STEMIs, usually occurring in the context of an inferior or lateral infarction. The posterior extension of an inferior or lateral infarct implies a much larger area of myocardial damage, with an increased risk of left ventricular dysfunction and death. Isolated posterior infarction is an indication for emergent coronary reperfusion. However, the lack of obvious ST elevation in this condition means the diagnosis often goes missed. But not for you, because you watched this lecture. Now, the characteristic changes for posterior MI include horizontal ST depression, tall, broad R waves, upright T waves, and a dominant R wave in V2. As you can see here, we see these changes. Now, when presented with the case of potential posterior MI, we can always complete a posterior EKG to clarify, in which we place the leads on the posterior chest wall in the following positions. V7 is placed at the left posterior axillary line in the same horizontal plane as V6. V8 is placed at the tip of the left scapula, and V9 is at the left paraspinal region. These are all in the same horizontal plane as V6. When completing a posterior EKG, we can see the ST elevation that we're all too familiar with in V7, V8, and V9. Moving on, split up. The third portion stands for LIT, and that's what myself and the rest of the EM family are at baseline. Now, for those of you who are unfamiliar, lit is when something is turned up or popping. We can use that in a sentence here. John, did you go to that party last night? Benny said, yes, that party was lit. Now, when referring to EKGs, LIT stands for AVL inverted T waves. Now, there is a paper that was published in 2016 which begged the question, does T-wave inversion in lead AVL predict mid-segment left anterior descending lesions in acute coronary syndrome? Now, they found that while T-wave inversion in lead AVL, regardless of other T-wave changes, had low diagnostic values for predicting mid-left anterior descending artery lesions, isolated T-wave inversion in lead AVL had a high specificity. As you can see here, we have an isolated T-wave inversion in AVL. And here once again, in a patient who presented with chest pain, we see the same isolated T-wave inversion in AVL. After 15 minutes later, we see that that isolated T-wave inversion in AVL has developed into the classic ST elevations in 2, 3, and AVF that we're all too familiar with in an inferior MI. Now moving back to our mnemonic, Wellin and Helen split up during the winter, and now they are all depressed. Let's talk about de Winter's criteria. Now, the de Winter's EKG pattern is an anterior STEMI equivalent that presents without obvious ST segment elevation. During this pattern, we see peaked symmetric T waves and ST depression at the J point with an upsloping ST segment. As previously mentioned, the key diagnostic features include ST depression and peaked T waves in precordial leaves. The de Winter's pattern is seen in only 2% of acute LAD occlusions and is definitely underrecognized by many clinicians, except for you, because you watched this lecture. So the key diagnostic criteria is tall, prominent, symmetric T waves in the precordial leads, upsloping ST segment depression greater than 1 millimeter at the J point in the precordial leads, absence of ST elevation in the precordial leads, ST segment elevation at AVR, and the normal STEMI morphology may precede or follow the T. de Winter's pattern. Here we can see the characteristic de Winter's pattern on this EKG. We see the depressed J point, the upsloping ST segment, and the upright T waves as well. And here once again, the de Winter's pattern. Now, unfamiliarity with this high-risk EKG pattern may lead to undertreatment with attendant negative effects on morbidity and mortality. So this is an EKG pattern that you definitely do not want to miss. Now moving back to our mnemonic, Wellin and Helen split up during the winter and now they are all depressed. Look at their faces. They're both very depressed at this point because they split up in the heat of cuffing season and more than likely will have to bear the cold winter without a boothang. But they are all depressed stands for AVR elevation when all other leads are depressed. Now this is representative of a left main coronary artery occlusion. Now the ST elevation in AVR is greater than 1 millimeter. ST elevation in AVR is greater than V1, and widespread horizontal ST depression, most prominent in leads 1, 2, V4, V5, and V6. Now the predictive value of ST elevation in AVR. ST elevation in AVR greater than 1 millimeter indicates proximal LAD or left middle coronary artery occlusion or severe 3-vessel disease, and it predicts the need for a CABG. ST elevation in AVR greater than V1 differentiates the left middle coronary artery from proximal LAD occlusion. Absence of ST elevation in AVR almost entirely excludes a significant left middle coronary artery lesion. Now bringing it all back together, Wellin and Helen split up during the winter and now they are all depressed. Wellin stands for Wellin Syndrome. Helen represents hyperacute T waves. Split up represents Scarbosa criteria, posterior MI, and AVL inverted T waves. De Winter represents de Winter's criteria, and now they are all depressed stands for AVR elevation in the setting of diffuse ST depression. Now these are all the additional EKG findings that you should be aware of beyond ST elevation and depression. This production was brought to you by E.M. Eddy.